How much longer do you live if you take a statin medication? Hi, I'm Dr. Eric Westman, and in this video we're going to get into the statin medication, the treatment of cholesterol in the blood, and how much benefit might you get from using medicine to treat the cholesterol in your blood. If you don't have my top 10 tips on how to start keto right, please look in the description below. I was sent this video from nutritionfacts.right. They're pretty much vegan, pro-vegan, sort of proselytizing group, but they do a lot of science reviews, and this one was very interesting because it gets into the weeds of if you do treat a cholesterol, what kind of benefit do you get? So let's see what Dr. Grieger at Nutrition Facts says.
In response to the charge that describing the benefits of statin drugs only in terms of relative risk reduction is a statistical deception created to give the appearance that statins are more effective than they really are, it was pointed out that the problem with describing things in terms of absolute risk reduction, or number needed to treat, is that they can depend on the duration of the study. For example, say there's some disease that has a 2% chance of killing you every year, but there's some drug that cuts your risk 50%. That sounds amazing, but then you realize that at the end of the year your risk will only have fallen from 2% down to 1%. So the absolute reduction of your risk is only 1%. If 100 people were treated with the drug, instead of 2 people dying, 1 person would die. So you'd have to treat 100 people to save 1 life. So there's like a 99% chance that taking the drug all year will have no effect on you either way. So to say the drug cuts your risk of dying by 50% seems like you're overstating things.
So that's exactly right. Let me unpack that a little bit. So you might be taking a medication to lower your risk, but at first you need to know what your risk is. So let's say your risk is very low to begin with. If a medicine lowers your low risk a little more, then you need to know that. If your risk is high and the medication lowers it a lot, then that would be a great medicine to take. But if your risk is already really low and you don't lower it much by taking a medicine, you end up, it's more like a judgment call, like a toss-up. Is it worth the side effects? Is it worth taking a drug that might have some expense to it? And here we're talking about statin medicine. So a lot of people come to my office to talk about cholesterol and statin treatment of cholesterol. The first thing I say to people is cholesterol is not a disease. Cholesterol at best is a risk factor for the disease called atherosclerosis. We're not trying to reduce your disease of high cholesterol. It's not a disease. The disease is atherosclerosis. Now, the complicating thing is if atherosclerosis affects the arteries of the heart, then that's called coronary artery disease, but it's still atherosclerosis. So if you're treating the cholesterol to lower the risk of atherosclerosis in the coronary arteries, you're trying to reduce heart attacks. And so the same for the arteries to the brain, the carotid arteries in the neck, or the arteries already in the brain. If they have atherosclerosis, you might get a stroke. So the major problems in the chronic medical conditions in the Western world can lead to heart attacks and stroke mediated through atherosclerosis, not high cholesterol. So high cholesterol is not a disease, even though I know so many people have flown to me cross-country to talk to me about this. You don't have to fly cross-country to ask me about this. Go to the Mayo Clinic Decision Aid, Statin Decision Aid. You can calculate your own risk. And it looks like they may have done that here because you get these little people on there, smiley faces. And so first thing you do is calculate your risk and then see what a treatment would do into adjusting your risk and make the decision whether it's right for you. So you don't need to come across country to talk to me about this. if you can, that's fine. Happy to talk to you. I'm in the insurance pay system, so there may be a little bit of a wait. But so first you want to know if you have atherosclerosis. That's the disease that we're trying to prevent by treating the cholesterol. And what I'm finding now is that doctors and mid-level practitioners, other like PAs and nurse practitioners are following guidelines that have kind of overly simplified the whole process by taking a cholesterol level, and if it's elevated, you treat the cholesterol level. And then you're not even sure if the person has the disease. I mean, this is kind of crazy. It would be like saying, I'm going to give you chemotherapy for a cancer that you might have. Well, no one would do that because the treatments are toxic, more toxic, and even statin treatment or other cholesterol treatment is not totally untoxic or benign. But so you would always be sure that someone has cancer before you're treating it. We're not doing that today in at least in my area of internal medicine and family medicine. What people are doing is following guidelines and treating a cholesterol level without regard to whether you have the disease they're trying to prevent. And so it's kind of crazy if you're 70 years old and you're an American and you have no evidence of atherosclerosis. You've had the testing done. We can talk about that. You have no evidence that you have this disease. You don't want to take a pill to reduce a disease you don't have. This is madness to do that. So here now we're talking about relative risk reduction and absolute risk reduction. And I know David Diamond, who wrote the paper that's being criticized here, saying that there was a deception. And well, isn't it a little deceiving if your risk goes from 2 to 1%? By a drug treatment, whatever the drug is, 98% of the time you're not going to have the problem, and now it's lowered to 99% of the time you don't have the problem, and you call that a 50% risk reduction, which it is. It seems 50% seems like a big effect when really it only goes from 2 to 1% absolute risk reduction. Now, if you have 50% risk and you lower it to 25% risk, that's a 50% risk reduction, relative risk reduction, and that's a huge effect. So the relative risk and that kind of reduction always needs to be contextualized by what the absolute risk is. And I know he goes through this really fast. It really kind of makes it a little harder to understand. But suffice it to say, you need to know what your risk of something is, and whether you have it even is better. That if you can prove that you don't have atherosclerosis at a certain age, I don't know if if you're 70, if you're 60, you have no evidence of atherosclerosis. I would be, pretty shocked if most doctors would say you should be on a medicine for a disease that you don't have by the time you're 60 or 70 years old, regardless of what your cholesterol level is. And certainly if you're following a low-carb diet and your cholesterol level has gone up, we're finding that this is a different situation altogether, because you need to take into account the triglyceride and the HDL in the blood, not just the LDL and the total cholesterol. This is called the metabolic syndrome. And so a low-carb keto diet addresses reducing cardiometabolic risk by addressing the metabolic syndrome and insulin resistance, which is manifested as triglyceride and HDL in the blood, not the old guideline way of looking at total and LDL cholesterol. So that's kind of my unpacking of the difference between absolute risk reduction and relative risk reduction. You have to know what your baseline risk is to really be able to interpret how much of a change it is.
But think about it. The benefits accrue over time. If you have a 2% chance of dying every year, year after year, after a few decades, the majority of those who refused the drug would be dead, whereas the majority who took the drug would be alive. So yeah, maybe in the first year you took it, there was only like a 1% chance it would save your life, but eventually you could end up with a decent chance the drug would save your life after all. This is the very reason why using relative risk makes sense. Absolute risk changes depending on what time frame you're talking about, but with relative risk, you know that whatever risk you have, you can cut that risk in half taking the drug.
Well, but I would still argue that if my risk is really, really low, even over a period of 10 years, that's more important than the relative risk of 50%. So the Mayo Clinic statin decision aid tool uses guidelines from many different organizations and allows you to put in your own information, your own lab test, your age, and your blood pressure. And interesting, LDL isn't even in one of the data points. You use total cholesterol and HDL in there from the blood work. So if you have that information, you can put it in there, and you can see what your risk is at baseline, and you can see it over time. And in that calculation, it's over the next 10-year period. So that timeline is important. Most of the studies that I've seen talk about your risk over the next 5 years or the next 10 years, and you can't really multiply it like he's saying, every 1 year, but you could if the data were presented in a way that was just 1 year. But I'm getting the sense that he's trying to push or support the idea of using statin medicines. And the interesting thing on the Mayo Clinic statin decision aid tool is that it's only for primary prevention. It's not for secondary prevention. Now that's, to break that down, if you've already had a heart attack or a stroke, that's called secondary prevention. And just about every guideline would say you need to be on a statin medicine. There are a lot of studies that show that there's pretty good benefit. And I have to say, I will relent in the given case, and if you've had heart disease or a stroke and you have no side effects from a statin medicine, I might say, yes, stay on it, given that individual's case. I'm not an anti-statin person. A lot of the keto people are being lambasted, in sort of a black and white sort of way. And I think it's an individual decision whether someone should take one, balancing the risk. And if it's primary prevention, meaning you have not had a heart attack or a stroke, you have no evidence of atherosclerosis, you may choose not to take it. And I think it's reasonable to do that. And it's not just me, it's organizations that actually involve the evidence-based medicine sort of point of view, including the statin decision aid tool from the Mayo Clinic. So you might want to be on one of these medicines, or you might not. But I'm getting the sense here that Dr. Grieger is pushing you toward using medicine. And of course, as Dr. Rob Lustig says, he's the emeritus professor out of University of California, San Francisco, good food is medicine. Bad food requires medicine, which leads to the point that maybe if you're eating in that, way, high carb and other sorts of non-low carb ways, maybe because the diet is not so good, you need to be on medicine. That's fine. But if you're using a nutritional approach that's good food is actually medicine. And someone remarked on one of my videos that yes, it's okay not to be on a medicine if you're an American, even though most people come to me on 5 to 10 medicines if they've been in the medical system. And we get to take away one by one, or sometimes 2 by 2, the medicines as people get better. So, so relative risk, absolute risk, know your baseline risk. These are really important points.
Now, statins only cut your risk 25%, but since cardiovascular disease is the #1 killer of men and women, if you're unwilling to change your diet, that's a powerful argument in favor of these kinds of drugs. You can see the same kind of dependency on trial duration looking at the postponement of death by statin use. How much longer do you get to live if you take statins? The average postponement of death has some advantages over other statistics because it may offer a better intuitive understanding among the general public, whereas a stat like number needed to treat has more of a win-or-lose lottery-like quality. So when a statin drug prevents like 1 heart attack out of 100 people treated over 5 years, it's not like the other 99 completely lost out. Their cholesterol dropped too, and their heart disease progression also presumably slowed down, just not enough to catch a heart attack within that narrow time frame.
Well, I know there's a lot of jargon here, but the main point is these medicines, whatever they are, to treat cholesterol, do not mean you're never going to get a heart attack. I see doctors, again, being very imprecise and with their language and fear-mongering that, if you don't take this medicine, you're going to get a heart attack. Well, even if you take the medicine, you might get a heart attack. So it doesn't eliminate the risk. And I think that's a big problem in communicating the realities and being transparent about the use of these medicines to treat cholesterol, which is not a disease. The disease is atherosclerosis. And the idea of just using these extrapolations now we're getting into of, well, how long might you live? And now we're getting into the kind of statistical changes and a sort of fantasy that even Mark Twain wrote about in a book on statistics. He pulled out a quote from Mark Twain that said, the way the Mississippi River is getting shorter and that, it's going to be gone by, the year 2000 and if you extrapolate totally. And so you're assuming lots of things in these sorts of statistical sort of I'd say machinations or manipulations, and a lot of it is to try to get you to persuade you to use a medication perhaps when it might not be appropriate.
So what's the effect of statins on average survival? According to an early estimate, if you put all the randomized trials together, the average postponement of death was calculated at maybe 3 or 4 days.
So that's not much.
What? I mean, who would take a drug every day for years just to live a few days longer? OK, well, first let's try to put that in context. 3 or 4 days is actually comparable to the gains in life expectancy from other medical interventions. For example, that's nearly identical to what you'd get from highly effective childhood vaccines. Because vaccines have been so effective in wiping out infectious diseases these days, they only add an average of about 3 extra days to a child's life. But of course, if your child is the rare life that gets saved, they gain an entire lifetime. That's why we vaccinate. It just seems like such a small average benefit because it gets distributed over the many millions of kids who get the vaccine. Is that the same with statins?
Well, but that's the logic there is, well, it's not much, but it's as much as any other intervention we use. No, it's not the same as lots of interventions we use. If you are given an antibiotic for sinusitis, for example, the number needed to treat is 1 or 2. In fact, in placebo-controlled trials, placebo often fixes sinusitis. So you would think that the number needed to treat is the number of people who get better based on the number of treated, and an NNT, or number needed to treat of 1, means every time you give the antibiotic, everyone gets better. But the NNT in placebo-controlled trials is more like 2 or 3, because the placebo actually can work on its own as well. But so to say that, it was very small, but it's the same as other interventions we use medically, I've seen that used to kind of support a position when that other position is not very strong. To me, that doesn't validate this weak sort of intervention.
An updated estimate was published in 2019, which explained that the prior estimate of 3 or 4 days was plagued by important weaknesses, and the actual average postponement of death was actually 10 whole days. Headline writers went giddy from these data, but they didn't understand is that this was only for the duration of the trial. So if your life expectancy is only 5 years, then yes, statins may only increase your lifespan by 10 days. But statins are meant to be taken a lot longer than that. What you want to know is how much longer you get to live if you stick with the drugs your whole life, and in that case, it's not living 10 extra days, but living up to 10 extra years. Taking statins can enable you to live years longer. That's because for every millimole per liter you drop your bad LDL cholesterol, you may live 3 years longer, maybe even 6 years longer, depending on which study you're reading. A millimole in US units is 39 points. Drop your LDL cholesterol about 39 points, and you could live years longer.
Important to note, those studies were in secondary prevention, so people who had already had heart attacks. And I agree that there may be a situation where you want to be on a statin medicine. But if you are primary prevention, you never had a heart attack or heart disease documented, or a stroke, and you're getting these measurements now. You can get the measurements of your arteries. You have to take matters into your own hands. If a doctor says, I want to put you on a statin for a disease, cholesterol, you say, well, cholesterol is not a disease, doctor. I know you're trying to prevent heart disease. What's the evidence that I have heart disease? And the doctor says, well, most people your age have heart disease. Well, then you say, well, actually, in my family, nobody had heart disease. And I don't think I should be on a medicine to prevent a disease that doesn't run in my family. So you could say, okay, I took this ultrasound test of the carotid, the neck arteries, and the aorta, and even show that to your best level of determination, because these don't require a prescription, you can actually get the ultrasounds of your arteries, an inspection that most doctors should be doing before they put you on a drug to reduce the disease that they're not sure that you have, but most people in America get it, but not everyone. So you see, we can personalize things a little better. It would be like, inspecting a house from the street and saying, well, it's a great neighborhood, and a bank's not going to give you a loan for a house unless it's a deep inspection to look inside the pipes and the walls. And so the way we've kind of dumbed down prevention to use cholesterol as a proxy, as a guideline-based tool to treat with a medicine is not really useful now. I mean, we can do better. You may have to take matters in your own hands by finding out ways to measure your own arteries and then asking that tough question, well, doctor, I'm not sure I have atherosclerosis. And you want to put me on a pill to prevent atherosclerosis that I'm not sure I have. Can we do a test to find out whether I have it or not? And that might, be a way to get some more information about your own body and your own health before someone's trying to meddle with it with a medication.
Exercise your whole life, and you may only increase your lifespan by 6 months. Stopping smoking may net you 9 months, but drop your LDL cholesterol about 39 points, and you could live years longer. You can accomplish that by taking drugs, or achieve that within just 2 weeks of eating a diet packed with fruits, vegetables, and nuts.
Well, here I got to call plant-based bias. There are a lot of ways to change your cholesterol levels, including a low-carb diet, but that's not what the video is. Oh, it's about statins. But they couldn't get away without talking about a vegan diet, so that's okay.
Want to know what's better than drugs? Something important and fundamental has been lost in the controversy about the broad expansion of statin therapy. It is imperative that patients be informed by their physicians, and hey, what about drug labels too, that not only their cholesterol levels, but also their cardiovascular risk can be reduced substantially by adoption of a plant-based dietary pattern, and without drugs.
Well, I would agree with that statement. You can take out plant-based, but in by many different types of dietary patterns. And I totally agree that the mainstream medical care really means medication care. I mean, when's the last time a doctor asked you how much you eat or what you eat, or asked you to write out on a piece of paper what you ate for the last couple days, just an example of what you ate? I require that in my office visits. People come back and I want to know what they're eating. That's the most important thing we can know about for someone's health, generally speaking. You can't get bad gas at the gas station. You can't get junk gas. We treat our cars better than we treat people. You can go in the gas station and then get bad food for people, but you can't get bad gas. So what you eat really matters, and it doesn't have to just be a one-size-fits-all plant-based kind of point of view.
In fact, dietary modifications for cardiovascular risk reduction including plant-based diets, have been shown to improve cholesterol status as well as obesity, hypertension, systemic inflammation, and on and on. The importance of this plant-based approach is magnified when one considers that, in contrast to statins, the side effects, weight loss, more energy, and improved quality of life, are beneficial.
Of course, you notice here the letter is from a doctor from the Physicians Committee for Responsible Medicine, which is basically the vegan promoting group, and they've done some research on it, which is great, but it's not like an independent source of information. Well, I have to agree that on average, the benefit of using statin medicines is small. There's more benefit if you have a higher baseline risk, meaning if you have primary prevention, you don't have a history of heart disease or stroke, you'll get less benefit with the treatment of these drugs than if you have already had heart disease, known as secondary prevention. And lifestyle is key. I totally agree on that point. It's just there are a lot of different lifestyles that have been tested, not just the one that they promote. And you can actually personalize your own decision. Go to the Mayo Clinic Statin Decision Aid tool website, and also get some tests to look at your arteries directly. Ultrasound, of course, has no X-ray radiation exposure. There are other tests called the coronary artery calcium score, or the coronary CT angiogram, to look to see if you have heart disease in ever increasing focus. But not all doctors prescribe these or recommend them, although some national guidelines have included the coronary artery calcium score. And if you have a coronary artery calcium score of 0, that pretty much says you don't have any calcified plaque in the area where your heart is, and confers a very good prognosis over a period of time. A lot of my patients now are coming in with a report from a company called Lifeline Screening, and they have a report on ultrasound, or they have the coronary artery calcium score. That requires a prescription, that a doctor has to prescribe it because of the X-ray exposure, I think. But you can get that for a small fee out of pocket. Of course, always explain to your doctor, who might be constrained by insurance costs, worrying whether you can pay for it, to say, well, doctor, I know the coronary artery calcium score is about $150. Look in your area and ask how much it is. That's generally what it is in our area. And say you'd be willing to pay out of pocket to grease the worry about whether their money is going to be spent for finding whether or not you have a problem. And it's kind of crazy, isn't it? We don't do prevention very well in the medical world today, so you have to take matters into your own hands. I hope that's helpful. If so, press like, subscribe so you don't miss out on further videos. And if you don't have my top 10 tips on how to start keto right, look in the description below. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.